So let's have a look here. Hi guys, it's Dr. Mo here from Inspire Medics. Good morning to everybody. So if you can hear me and if you can see me, give me a quick thumbs up. We've already got about 45, 46 attendees so far. So let us know where you're coming from. So if you're coming from the UK, if you're joining us from Africa, Nigeria, Pakistan, India, whichever country you're coming from, there's a chat box down the side. Kulsum is from UAR. Jonah has given us a thumbs up. Muhammad Ali from the UK. Shahid from Pakistan. Dr. Sandu will be joining us shortly as well. So guys, if you can hear me, just let me know. If you can see me, let me know. Inar from UAE, Lilia from Algeria. Let's see, Nima from the UK, Himanshu from India. So we've got Azishan from Pakistan, Ibrahim from the UK, Sumaya from London, Hijra from, whoa, starting to go really fast now. Shazia from Northampton, Abiola from Nigeria, Shushmitha from the UK, Fatu Ebitisam from the UK, Davika from Kenya, and Shri from the UK. Okay, guys, what we'll do is we'll get started very, very soon. Zaki from Algeria. Hi, Zaki. Muhammad Ali from Birmingham. Today's teaching session is going to be about diabetes and the other topic. Let's see what the other topic was. Let's see. Diabetes and migraine. So these are the latest NICE guidelines for diabetes and migraine, which will be super, super useful for the PLAB exam, for PLAB 1 and PLAB 2. Ledum from the UK. Okay, so guys, what we'll do is we'll get started. There will be lots of opportunities to ask questions and answers, but I'm just going to do a screen share so you can see what my screen is like. There's a couple of things to bear in mind. We are going to release some very, very large discount codes for PLAB 1 and PLAB 2 products on our website. So hang around for the middle part of the webinar and the end of the webinar, if that's okay. So guys, just give us a second. Sorry guys, just give me a second. I'm just gonna grab some stuff. Sorry about that, guys. So okay, morning, child. So we are gonna do some very, very large discount codes for our PLAB 1 and PLAB 2 products. We are going to release them probably towards the middle end of the webinar, so please hang around till the end if you can. But basically what we'll do is we'll get started. Good morning to anybody who's just joined us. It's Dr. Mo here from Inspire Medics. The topic is diabetes and migraines, the latest NICE guidelines which are relevant for the PLAB 1 and the PLAB 2 exam. Like I said to everybody, about halfway into this webinar, we're going to have some very, very large discount codes being released. And also what we're going to do is we've got another webinar after this, but I'll give you some details about that very shortly. So a quick shout out to everybody. If you are joining us from the UK, let us know. If you are joining us outside the UK, drop us a message in the chat box. And there's a Q&A button which you can actually press if you want to obviously ask us any questions. So Ahmet from the UK, I take it this name is Turkish, Ahmet, or am I wrong? If I'm wrong, let me know. If not, just drop us. Alabi from Nigeria, Olugbenga from Nigeria. Ahmed said yes. Iman from Saudi Arabia. Adebayo from Nigeria. So let's get started, guys. Oh, hang on. Shazad BD, Marwa from Egypt, Fatima from the UK, Yuwandi from Nigeria. Good morning to everybody. Godwin from Nigeria as well. So let's get started. We've got an international webinar today. Fozia from the UK, Fatima from the UK, Khatija from Pakistan. So guys, I'm going to do a screen share. Maria from the UK says keep on coming. Let's do a screen share, guys. Thank you for letting me know where you've come from today. Ola from Nigeria. So let's do a quick screen share. Mohammed from the UK. Okay, so if you can see my screen, this is the diabetes teaching. Please let me know. Quick thumbs up, everybody, if you can see my screen. Okay, Shazia's put a thumb up. Okay, good. That's fine, guys. As long as you can see my screen and you can hear me. So today's topic is, as I said, diabetes and migraine. Now, the key things we're going to try and go through here are 2 or 3 very fundamental learning points that you're going to have to take away that are going to be relevant for the exam. So what we're not going to do is overload you with information. We're not going to give you like 1,000 learning points. I'm going to give you 3 key learning points from the latest NICE guidelines. And then Dr. Sandhu is also going to give you 3 key learning points. As long as you can take those 3 key learning points away, you'll be fine for the exam. And so these are like the super important learning points, which always come up repeatedly again and again for PLAB 1 and PLAB 2. So the outline is basically going to be 15 minutes for the new diabetes guidelines. Then you can ask questions for 10 minutes. Then Dr. Sandhu will do 15 minutes on the migraine new guidelines, and then Q's and A's, and then we'll have general question and answers at the end. So let's get started. Let's do a quick recap. So these are World Health Organization definitions that the NICE that NICE use in the UK. So this is a recap, guys. You should already know this information. It's most likely going to come up in PLAB 1 and probably PLAB 2 if you've got a station on diabetes, which is a result station. So how do you diagnose diabetes? So there's 2 ways that you diagnose diabetes. Those patients who are symptomatic and those who are asymptomatic. And there's a different criteria for each of those groups. So if a patient's symptomatic, you should know this: polyuria, polydipsia, weight loss, tiredness. These are classical symptoms of diabetes. If they're asymptomatic, of course, they have no symptoms. So if you have a patient who is symptomatic with diabetes type symptoms, you only need 1 HbA1c, which is raised, or a fasting plasma glucose, which is raised, and then you can diagnose diabetes. And the cutoffs are listed. So HbA1c of 48 millimoles per mole or more, and a fasting plasma glucose of 7 millimoles per liter or more. Either one can be used. And in the UK, we mainly use HbA1c. So symptomatic, and 1 single reading of that or more is equals to a diagnosis of diabetes, which of course is bad news for the patient because they're going to be upset. But as a clinician, these are key values we need to be aware of. Dr. Sandhu is going to join us very shortly, so he's going to keep an eye on the chat box whilst I'm talking. If the patient is asymptomatic, so they have no symptoms, then basically what you need is 2 separate blood readings of the values given above. And if you've got 2 separate readings, then you can go ahead and diagnose diabetes. So if a patient, for example, has a HbA1c of 48 millimoles per mole, and you check it again 2 days later, and it's 48 millimoles per mole again, you can confirm diabetes even though they have no symptoms. Now, for the purposes of PLAB 1 and PLAB 2, pre-diabetes is classified as a HbA1c of between 42 to 47. So this means that millimoles per mole. This means that the patients are not diabetic, but they are high risk of becoming diabetic in the near future or the late future. So what we generally do is, if we've done a HbA1c and it's come up between those 2 numbers, or between 42 and 47, we recheck it after 3 months to make sure it's not creeping upwards. If it's 41, they're not diabetic, but you may want to counsel them that they're getting close to pre-diabetes. But these are the key numbers. Hope that makes sense. Relatively straightforward, relatively easy. You should know this from the top of your head. Let's move on to the actual NICE guidelines. So in September 2019, NICE actually changed their guidelines in light of new evidence from the Lancet, from various studies, from meta-analysis. And that's what NICE does. NICE is a UK independent medical body which provides guidelines and medical information for doctors and best practice, and it's free. Inside the UK, it's free. So I know you can't access it always outside of the UK if you're joining from Nigeria, Saudi Arabia, for example, or India. Okay, so in terms of the diabetes and hypertension guidelines, these are the ones that have changed. Now, if you joined us for our hypertension webinar last month, you would have come across these guidelines, but we're going to specifically focus in on the diabetes ones today in relation to hypertension. Essentially, what's happened is that the diagnostic criteria and the thresholds for diabetes have become the same as non-diabetic patients. As long as you remember that, you're going to be fine. So how do you diagnose hypertension in a diabetic patient? Well, if they've got a clinic blood pressure of more than or equals to 140/90, you may want to repeat this obviously 2 or 3 times over a space of 2 or 3 weeks. If they've got that reading or cutoff, then you can diagnose hypertension in that diabetic patient. The other cutoff is ambulatory blood pressure readings. So this is either home blood pressure readings or they've got a Holter blood pressure monitor. The cutoffs are lower. Obviously, they're not in a clinic situation. So if it's consistently above 135/85 in terms of their home blood pressure readings, you can diagnose hypertension in that diabetic patient. So first of all, know the diagnostic cutoffs. Secondly, know what the targets are and the thresholds. So once you've got a patient who's diabetic and has been diagnosed with hypertension, the targets are less than 140/90. Now, the reason I've put a star next to that number is there are two exclusion criteria for that. If the patient has CKD and is diabetic, there are different targets and thresholds. So you want to aim for different targets. The targets are a lot lower. So it's tighter blood pressure control because obviously those patients have got kidney damage. In order to find out the thresholds for those numbers, the cutoffs, please refer to the NICE-CKD guidelines. So we're not going to cover them in this webinar because those are separate guidelines altogether. CKD is chronic kidney disease. Of course, you can have stage 3, 4, and 5. Also, the cutoffs are higher for elderly people. So those over the age of 80, you want to aim for a blood pressure target of less than 150/90. And the reason is elderly people are more frail, they're more weak, they're more liable to develop postural hypertension or falls. So you want to give them a bit more leeway. So that's the other thing to remember. I've put a star next to 140/90 as well in terms of less than that target. And the reason again is because those numbers are now the same as non-diabetic patients. That's the new changes to the guidelines in September 2019. And finally, if a patient is diabetic, the first line option, if the patient is diabetic and hypertensive, is an ACE inhibitor or an angiotensin receptor blocker if they're African Caribbean. But if you remember ACE inhibitor for the purposes of the exam, you'll be fine because that's more than adequate even if they are African Caribbean. There's a little bit, the studies have shown that an ARB, they're a little bit better for African Caribbean patients, but ACE inhibitor should be first line generally across the board. Okay, so that is the first key learning point. The first key learning point is that the hypertension guidelines for diabetic patients have changed to become more in line and equal to those without diabetes. So non-diabetic patients and diabetic patients, the parameters are now effectively the same. Remember that. As long as you remember that, you'll be good for the exam. Second key learning point. In terms of diabetes and cholesterol, you should be offering primary and secondary prevention for cardiovascular disease risk. What does that mean? So diabetic patients have, of course, increased risk of heart attacks and strokes. Therefore, in order to reduce their risk, you should be offering them a statin. So for primary prevention, i.e. those who have never had a heart attack or a stroke before, you should offer them atorvastatin 20 milligrams if their Q risk is equals to or greater than 10%. So Q risk, guys, is a risk stratification tool. It basically calculates different parameters like lipid profile, blood pressure, height, weight, ethnicity, age, and it combines all those numbers together and it gives you a 10-year risk. And if the 10-year risk is greater or equals to 10%, then you should start those diabetic patients on 20 milligrams of atorvastatin to reduce their risk of heart attacks and strokes. If, however, that diabetic patient already has had a heart attack or a stroke or has peripheral arterial disease, then in that case, this load them up with atorvastatin and the dose is 80 milligrams. The old guidelines used to recommend simvastatin. We no longer use that in the UK because it's not recommended in this scenario because the evidence base is a lot stronger for atorvastatin. So second key learning point, everybody, primary prevention of cardiovascular disease in diabetic patients is 20 milligrams of atorvastatin if the Q risk is greater or equals to 10%. If, on the other hand, they've already got ischemic heart disease or you're trying to secondary prevent cardiovascular disease, the guidelines are atorvastatin 80 milligrams. Second key learning point. Let's move on to the third key learning point. So in the PLAB 2 exam, it's likely that you will be asked or you will have a station about diabetes management. And it's likely that in the PLAB 1 exam, you'll also get questions on diabetes management. So the algorithms have changed for chronic disease management for diabetes in the September 2019 guidelines. So I'm very quickly going to go through those changes. Before, the algorithm was very, very concrete. First you do this, then you do this, then you add this specific drug. Now there's a lot more flexibility. You can actually choose what drug you want to add in on step 3. Okay, so let's get started. So step one, generally speaking, is lifestyle. You give the patient diet, exercise advice, but usually step one, you would also be advised to recommend metformin at the same time. So NICE has said actually this load up metformin into those patients because it reduces weight, it reduces HbA1c, it reduces long-term risk of the HbA1c getting higher. So do step one and step two together if you can. If the patient obviously doesn't want to start tablets, then talk about lifestyle first, low carb diets, reducing the sugar in their diet. And then, of course, you can move them on to step two. Step two is metformin. From step two, you can then move on to step three, which is dual therapy. So you can add on another drug to metformin, and I'll go through which of those 5 drugs you can add on. So there's five other drugs, there's 4 or 5 other drugs you can choose from, which you can add on to step three, and you can choose from any one of those drugs. Step 4 is triple therapy. So the patient will be on 3 anti-diabetic drugs, or at that point, you may decide that actually they need to go on to insulin. So just to recap, lifestyle, metformin, 2 anti-diabetic drugs, and then 3 anti-diabetic drugs or insulin on step 4. Now, depending where they are in that algorithm chain, you want to change your target HbA1c. So if they're on lifestyle alone, so this diet, the target HbA1c is 48 millimoles per mole. If they're on metformin alone, this metformin alone, and lifestyle, of course, as well, then the target is still 48 millimoles per mole. Once you start moving on to dual therapy and triple therapy, the thresholds become higher. The target is 53 millimoles per mole. And again, the same for triple therapy. Now, the reason NICE did this is because they found that patients who are on triple therapy or dual therapy need more relaxed control, because there's a higher risk of hypoglycemia. So you let the HbA1c rise a little bit higher in terms of your target to avoid hypos. Hypos are associated with longer term poor prognosis. Good morning to everyone who's joined us. I know another 30 people have just joined us, by the way. With this getting into the NICE algorithm for diabetes. Okay, guys, so when to step up? So again, when do you step up the treatment? So in terms of lifestyle alone, you step up if they reach 48 millimoles per mole or more. If they're on drug therapy, you should step up if they hit 58 millimoles per mole or more. And that's the cutoff. So then at that point, you should be thinking, okay, I need to move on to the next part of the algorithm, either metformin or dual therapy or triple therapy, depending on those cutoffs. Now, you actually have a choice of 5 other drugs you can add on in terms of dual therapy or triple therapy. You can choose any one. So at dual therapy, let's say the patient's on metformin, and they're on their HbA1c is 59 millimoles per mole. So that means you need to step up. So down here in red. They can now move on to dual therapy. You would recommend dual therapy, but you can choose any one of these 5 other drugs to add on. And NICE has been really flexible because NICE recognizes that some of these drugs have side effects and complications, and they're not suitable for all patients. And you need to make that call as a clinician, which one's going to be most suitable. So what are the options? We have sulfonylureas, which is, for example, gliclazide. That's usually second line for most doctors to add on after metformin, but there's a risk of obviously hypoglycemia. Then you have your gliptins. An example is sitagliptin. These are DDP4 inhibitors, but one of the risks of gliptins is that there's an increased risk of pancreatitis. You also have pioglitazone. It's the only glitazone which is licensed in the UK, but the side effect profile is that it can cause weight gain, it can exacerbate heart failure, it can increase the risk of fractures, and it can increase the risk of bladder cancer. Then you have SGLT2 inhibitors. An example is canagliflozin. What these do is they allow the kidneys to excrete glucose within the urine. So you basically pee out, you urinate glucose. As a result, one of the side effects of that is you're an increased risk of UTIs, genitalia infections, and also DKA. However, if the patient has already has cardiovascular disease, they've had heart attacks or strokes in the past, there has been shown in the studies that there is a CVD protective benefit of using SGLT2 inhibitors. And then finally, GLP-1s, these tend to be used at step 1, 2, 3, 4, step 5 of the algorithm, or step 4. So you're moving towards the end of the algorithm. And these are generally injectables, so exenatide. They're quite expensive, by the way, in the UK. They can help with weight loss, but one of the side effects is pancreatitis. So you have a choice of different ones. Remember, GLP-1s towards the end of the algorithm, step 4 and 5. Otherwise, you can choose any one of the other 4 that I've mentioned. Remember with metformin that if the EGFR is less than 30, you should stop it. If it's less than 45, you should reduce the dose. And metformin is one of the only biguanides available in the UK. Okie dokes. So guys, those are the 3 key learning points. New hypertension guidelines for diabetes, the new cholesterol and cardiovascular disease management for diabetes, and the algorithms change, which is relatively straightforward. Don't worry if you've missed the beginning of this webinar. We are recording it. We will send you the link. Welcome to all of you if you've just joined us. What we'll do is we'll quickly start taking some questions and answers. We've got a lot to get through, of course. Whilst you're thinking of your Q's and A's, you can use the Q&A button down below, and I'm going to go through some of the products we have on our website whilst you're thinking of those questions. So I'm just going to stop the screen share for a moment. Let's see here where the chat's gone. Okay, Rakita, the webinar started at 11 o'clock about 20 minutes ago. Please use the Q&A buttons if you've got any questions about the diabetes topic I just did. Now, quick hands up, who is doing PLAB 2 very soon? If you don't mind, very quick hands up if you're doing PLAB 2 very soon. Okay, 12, 13, hands up if you're doing PLAB 2 very soon. 22, 23, 20, okay, hands down, just gonna put everyone's hands down. Quick hands up, who's gonna be doing the PLAB 1 very soon? Quick hands up, who's gonna be doing the PLAB 1 very, very soon in the next 3 months or so? Okay, hands up, about 16, 17, 18, 19, 20. Okay, guys, what we're gonna do is I'm gonna do a quick screen share. We have a online PLAB Academy. It's 10 days long. We cover almost all of PLAB. All the different scenarios that can come up for the PLAB 2 exam, and we will have a special discount code which we will release at the end of this webinar. So who's interested in joining the PLAB 2 Academy? I'll show you the product, because if you're interested, the more people, so what we'll do, if more than 10 people join, we'll offer a lower discount code, and if more than 20 people are interested in joining, we'll offer the higher discount code. So let's just go to the, we're gonna do a screen share for everybody. Okie dokie. So if everybody can see this, just give me a quick shout out. Quick thumbs up. This is the PLAB 2 Live Online Academy. It's a 10-day course. There are a range of different dates available. So we've got August, September, October, November, December. You can choose what date depending on when your exam is. The current price is $249.99 for a 10-day online academy. The times are UK GMT. So we do 3 hours every day, Monday to Friday, between 10 o'clock in the morning to 1 p.m. And we do that for 10 days, Monday to Friday. Myself and Dr. Sandhu will cover all the hot topics, the cases that are most likely to come up in the PLAB exam. We'll take you through the relevant guidelines. We'll take you through interpersonal skills, data gathering and management. And we'll take you through what the examiners are looking for in candidates who score the highest mark. It's a really, really valuable webinar. I think 2 of the candidates who are already using this webinar on it, I think are Charles and Henry, and I think they're with us today. So guys, what we'll do, so what I'll do, I'm just going to lower everybody's hands. Yeah, we do Limia, we do Mox as well. Vikas, if you don't mind, can you lower everybody's hands for a second? Okay, just a second. So guys, if you give me a moment.
You just need to activate my video.
Vikas, do you need the link to get in?
So I'm already in, but I just need you to make me a host.
Ah, I see. Okay. Guys, just give me a moment. I'm just going to do. Okay.
First one.
So Vikas, you should be a host already. Guys, just give us a second. I'm not sure what's going on here. It's going to be...
No, I'm in the right one, bro. I'm there with you. So you should have made me a host, didn't it? So I don't know what's going on here. So I can see everything. I can't do anything else.
You share screen, right?
Hold on. Yeah.
And do your video.
No, it doesn't work. Look, it says you have to let me go. Look, the video cannot start because your host has stopped it. So you just need to activate the video.
Guys, just give us a second. There is a quick slight technical issue. We'll have it sorted in the next 1 or 2 minutes. Hi guys, sorry about that. So if you can still see my screen, guys, just give me a quick thumbs up. If you can see the online website, which I'm just showing right now. Quick thumbs up, guys, if you can see. Okay, fantastic. So you can all see it. That's good. So guys, what we'll do is if more than 10 people are interested in joining, we'll offer 1 discount code. And if more than 20 people are interested in joining the PLAB2 Online Academy, we'll offer a much, much larger discount code. So what we're going to do, if you don't mind, a quick hands up again. Who is interested in attending the PLAB2 Online Academy for Inspire Medics? Quick hands up. So we've got 3, 4, 7, 8, 12, 13. So at the moment, we can only do the lower discount code, guys. 16, 18, 19, 19. If it goes past 20, what we'll do is we'll do the higher discount code for okay, 22. Fine, guys. At the end of this webinar, we'll be releasing the higher discount codes. Henry's just put in a comment, good morning, currently 5 days on the PLAB2 Online Academy, and I can confirm that it's been very beneficial. Henry, can I unmute your mic? Would that be okay? I'm just going to unmute your mic so you can perhaps give us a very quick idea of what the Academy is like for everybody. So give me a second, Henry. I'm just going to find your name here. Okay, guys, so this is Henry. I think he's from Nigeria from what I remember. We're just going to get Henry to speak a little bit for us. I can't find his name for some reason. Oh, hi, here we go. So Henry, you're going to be on in, okay, so Henry, I've unmuted your mic. Okay, Henry. Hello.
Good morning, Dr. Mo.
Hey, morning. So this is Henry. Are you speaking from Nigeria, Henry?
No, not in Nigeria. I'm actually in Grenada, the Caribbean.
Grenada. Okay, apologies. Do you want to give everybody a quick flavor of what the PLAB2 Online Academy has been like for the last 5 days or so?
Absolutely, Dr. Mo. Good morning, everyone. Sincerely, I'm currently 5 days on the PLAB2 Online Academy, and so far it's been awesome. The 3 hours is just the right time because you don't get to become fatigued or lose concentration, stop dropping level of concentration. So I strongly will recommend it to you guys, seriously. And then the price is fantastic. The price is really, really very fair. So I'll just encourage everyone to please. So at the end of the day, we'll all hit our target and make PLAB2, pass PLAB2, 4th attempt. I believe that's everybody's desire. All right.
Fantastic. Henry, thank you so much. What time is it now in Grenada, by the way?
It's just 6:29 here in Grenada.
Is that the morning or the evening?
Yeah, morning.
Oh, wow.
Yeah, we're just about 4 hours behind, I think. Yeah.
Henry, thank you so much, by the way, for obviously doing the shout out for us.
You're welcome, Dr. Moore.
Okay, thank you. I'll see you tomorrow, hopefully.
All right.
Okay, guys, so that's the PLAB 2 online academy, which we highly recommend everybody joins. So the second thing that we have, I'm just going to do another screen share, is let's have a look, is the PLAB 1 mock Zoom mock. So we have a PLAB 1 Zoom mock. If everyone can see my, let's have a look. If everyone can see my screen, just quick thumbs up, please. So this is a PLAB 1 Zoom mock. Okay, good. We have dates this before, about 2 weeks before the actual exam. So there's August, October dates. Again, we're going to do a discount code. So if you're interested, we'll do a small discount code for up to 10 people, a much larger discount code if there's more than 20 people interested. So quick hands up who's interested in the virtual Zoom PLAB 1 mock. It goes from 10 a.m. in the morning till 7:30 UK GMT time. We go through 180 high yield questions, and then we break those down. So first of all, we do them in real exam settings. And then what we do is we go through the breakdown of those questions afterwards in the afternoon. So there's 7 people so far, 8 people so far who's going to be interested, 10 people. Okay, guys, one more and we can offer okay, good, 11. We can offer the higher discount code. So guys, the discount code is only valid till tonight. It's only valid for the next 8 hours, and we'll release the discount code. Actually, what we'll do is I'll release the discount codes as Dr. Sandhu is doing his presentation. So I'm just going to stop the screen share there for a second. We've got a couple of questions about the diabetes section. Let's see. So how will patient represent himself during PLAB 2? I'm not sure what you mean by that. It's anonymous. I'm not quite sure what you mean by that question. So if you don't mind clarifying it, whoever that was, I would appreciate it. Nadir, what is the management if you suspect heart failure in a GP clinic? So Nadir, is that in relation to diabetes? Because if it is, you would usually start metformin, but you'd avoid you'd avoid the glitazone, so you'd avoid pioglitazone. But if your question's about heart failure in a GP clinic, we're doing a separate webinar on that later, or you may want to drop us an email because today's topic is obviously diabetes. From Anonymous, can you just combine any of the drugs for dual or triple therapy, or is there something particular to consider in combining the drugs? Anonymous, you can combine any of the drugs. Just choose a drug that might be most suitable for the patient. For example, if he's a lorry driver, probably avoid gliclazide, because if there's a risk of hypos and he's driving long distance, that's dangerous. So this, tailor it to the patient. If the patient's postmenopausal and their increased risk of fractures, obviously avoid pioglitazone. So you just need to choose the right one, but essentially you can choose any from the 4 or 5 in dual or triple therapy. Some of us, some of us don't have dates yet. How do we benefit from the discounts? Okay, guys, if you haven't got your dates for the PLAB 2 exam yet, book it today. And what we'll do is when we open up our dates for later in the year, we'll move you along. So you've already paid, you've secured your place, you've got the discount code, and then we'll shuffle you along into, for example, January, February, March, April. That's not a problem. We'll open up some more dates later in the year and you can choose which date. So it doesn't matter which date you choose on the product page. Drop us an email, say I've paid, I've chosen this date, but I want to move on to the new date later in the year, and we can do that and we'll reserve your place. Okay, guys, just one last question and then we'll move on to Dr. Sandhu. To offer for an implementation of insulin, what level of HbA1c should be? So generally speaking, if you're offering insulin, Lilia, you are moving on to step 4 of the algorithm, and the HbA1c needs to be above or equals to 58 millimoles per mole or more. Okay, guys, so I think that's that done. Oh, Hannah, which anti-diabetic drug is better in a patient who has hypertension and cardiovascular disease as well? So the best drug, Hannah, in that scenario is going to be an SGLT2 inhibitor, because it's got a protective cardiovascular disease risk profile to it. Okay, guys, give us a moment, guys. I'm just going to get Dr. Sandhu on, if you just bear with me.
So
Hi guys, sorry about this. Dr. Sandu is going to join us in about 5 minutes. He's having some slight technical issues. Charles has commented, you become a better doctor with this course and you are sure to sail through PLAB 2. Fozia has asked a question, does your online course involve the latest pattern according to COVID-19? The short answer is yes, Fozia. We include the COVID-19 guidelines, but really there's not big changes to the management. They're really looking, because the COVID-19 guidelines are changing on a daily, weekly basis. So really they're not going to be factoring that in too much into the PLAB 2 exam. Okie dokes. Godwin's got a question about the PLAB 2. How do you conduct your mock exams, given that we need to show facial expressions and empathy sometimes? Okay, Godwin, we can assess that in our virtual mock over Zoom. We also have face-to-face. Obviously, that's a bit more difficult if you're not in the UK, but we can assess your facial expressions via Zoom and your communication skills. It's not a problem. It's never been a problem in the past. Okay, guys, I'm just waiting for Dr. Sandu to join. He's having some slight issues coming on board. So if you give me a second. Shazia, you don't get notes from the course. You can take notes as you go along. The reason is, Shazia, we've had plagiarism in the past and then materials being released, and that's been really, really upsetting for the whole team. So that's one of the reasons why we haven't done that. Okay, dokes, let's see. Vikram says, how can we do mock tests specifically for SimMan? SimMan's difficult, Vikram. That needs in-person obviously practice. We do have a video course for PLAB 2, which I'll give you the URL for very, very soon. We do 7 or 8 different SimMan stations, which you can see how we do. How many mocks? I think that's from Zishan. Zishan, we do a range of different. We do a different number of mocks. I'll put the link in very, very soon once Dr. Sandu appears on the screen. Samira, please drop us an email if you want to book in for the mocks. Let's see what else is. Mohammed's got a question. Why not ACE inhibitors? I'm not quite sure what that question refers to. But Mohammed, we also cover the mannequin and SimMan as well. Guys, give us a second. We're just going to get Dr. Sandu up and running. Guys, sorry about this. Having some slight technical issues. Dr. Sandu should be with us in the next 2-3 minutes. Once he comes up, I will answer any other questions. I will also obviously give the discount code. So Dr. Sandu, give us a quick shout if you can get in. Okay, give us a second, guys. I think. Okay, attendees. So Dr. Sandu, if you just rejoin, I'll see if I can activate you. So we can hear you, VCAS. Okay, not a problem. I'll tell you what. VCAS, do you want to come around this side?
Yes. Well, let's do it like this. I'll share my screen.
Okay, fine.
Should still be able to do it. So sorry, guys, unfortunately, you can't see me. Of course, many of you probably know me from before. So Dr. Sandu, the co-founder of iMedics and NHS England, clinical entrepreneur as well. Thank you, Henry. Thank you, Charles, for your feedback. These two guys have been doing very well on our online PLAB 2 Academy. They're 5 days in. They've still got another 5 days to go. So appreciate your good feedback, guys. Thank you very much for that. So I'm going to start sharing my screen. And I'm going to be talking a bit about migraine. So can you see this, Mo?
Yeah, I can see it. Try doing your video quickly. If it doesn't work, we'll move on.
So, no, nothing. Yeah, I can't know. So, okay. So, guys, so you can all hear me, yeah? Can you see? You see the private point?
Yeah, we can see. Yeah, we can see and hear you. Yeah.
Good, good, good. So, basically, guys, so the hot topic number 2 then is migraine. So, migraine is a kind of common thing tested both in PLAB 1 and in PLAB 2. So today we're going to have a chat a little bit about what we already know when it comes to migraine, useful updates from the NICE guidance, so up-to-date current NICE guidance on migraines, and of course give you the opportunity to ask us some questions as well on this topic, commonly tested in PLAB 1 and also in PLAB 2. So what is migraine? What is it actually defined as? Well, essentially a migraine is basically what we describe as severe, intense headaches that are normally, but not always, one-sided. And patients will normally describe it as a throbbing or a pulsating sensation. So they normally say, doctor, I've got this really intense throbbing on the right-hand side or on the left-hand side, but don't be alarmed. Sometimes it can be bilateral as well. Number two, they get other symptoms with it. So things like sensitivity to light and what we call photophobia. Phonophobia, so sensitive when they're hearing sounds. And of course, they often report some nausea and vomiting as well. Then you've got different types of migraine. So you've got a migraine with aura and a migraine without aura. So an aura is something, the exact textbook definition of aura is what we call a transient focal neurological symptom. So some kind of neurological abnormality that happens first, and then they get this one-sided throbbing headache. So normally the classic three, they either get what we call scotoma, so they get visual problems. So normally the classic one is zigzag lines about 5 to 10 minutes before the headache starts. Sometimes they can get sensory symptoms like pins and needles. And normally these will come just before the headache starts, but in a small number of cases, they can get the symptoms and the headache at the same time. So what causes it? Now, this is important to know because you can be asked about this both in your history when you're doing a headache examination, and also when you're examining the patients and you're thinking about what kind of things I should be asking in the social history for triggers, or indeed, of course, what are the common causes in a PLAB 1 exam. So triggers, we don't really know what actually causes this condition. It can be spontaneous and normally they may not find a cause, but there's lots of things that we should be thinking about. So patients who've got a disturbed sleep, those who miss meals quite regularly, those who drink a lot of coffee. So, whether that's tea, whether that's coffee, or indeed the current craze, which is energy drinks, and always ask about that in your history. How much coffee do you have in it, or do you drink any energy drinks at all? And what you may find is people are drinking highly caffeinated energy drinks and they're having lots of them to keep themselves awake. Lack of exercise is also a trigger. Menstruation, so we'll talk a little bit about menstruation later in the presentation because NICE has some specific guidance on how to manage menstrual migraine. Then you've got things like stress, obesity, sleep problems, and of course an interesting one of overusing acute migraine medications. And NICE also gives us some advice on how we should manage this, and we'll talk a little bit about that as we go through the slides. So how do we actually diagnose it? Well, you make the official diagnosis of a migraine with anybody who has a headache and at least 2 of the following characteristics, okay? So number 1, it's unilateral, so one-sided, but it can be bilateral. So don't be surprised if a patient has it on both sides. Number 2, they describe a pulsating quality, so maybe a throbbing or a banging headache. Number 3, it's of moderate or severe pain and intensity. So if you see anybody who has a migraine, they say the headache is so severe that they have to go and lie in a dark room or a quiet room, and then the symptoms start to ease off. And number 4, they tend to be aggravated by or cause them to avoid routine activities that they would normally do, like washing, dressing, going up and down the stairs. And then you've got the second criteria, so headache with associated symptoms, including at least one of the following: headache with nausea and vomiting, or a headache with photophobia and phonophobia, so sensitivity to light and sensitivity to sound. Now, of course, the specific advice that NICE gives us is that the headache must not be better accounted for by another diagnosis. So if we're talking about photophobia and you're doing a PLAB 2 case, you need to make sure that you ask about any rashes, any stiffness in the neck, any fevers, because then you're starting to think, actually, this could be meningitis rather than migraine. So from a PLAB 2 perspective, you would ask about your secondary symptoms to exclude other diagnoses, and that would then lead you to your diagnosis of migraine. So to specifically diagnose somebody with a migraine with aura, NICE says you have to have at least 2 attacks with the following criteria. So they have a headache with a visual symptom, such as a zigzag line or a visual aura. Number two, a sensory problem such as one-sided pins, needle, or numbness. Or number three, a brief speech and language symptom such as a difficulty getting some words out. Well, the most important thing here is that these are reversible, fully reversible, and normally only last 5 to 10, 15 minutes, and then they lead to this problem. And then, of course, the other criteria to be mindful of when you're talking about a migraine with an aura is they have the second criteria. So if they don't match this criteria, the one that we've just discussed, they can go back to this one here. So at least 3 of the following. So one aura symptom that occurs gradually over at least 5 minutes. Number 2, 2 or more aura symptoms that occur in succession. Number 3, each of these individual aura symptoms last between 5 and 60 minutes. Number 4, at least one of these aura symptoms is unilateral. At least one of the aura symptoms is positive, and the aura is accompanied by or followed by a headache within 60 minutes. And of course, you should be confident that there's no other underlying cause for the headache. Now, atypical aura, this is something you should be thinking about. So sometimes people will ask, well, what's the difference between a migraine and an aura and something more serious like a stroke or a TIA? Well, atypical aura, and that's something we should be worried about, indicates that there's a motor, and these are motor brainstem or retinal symptoms. These are not what we call typical aura. So depending on the clinical situation, you may have to admit the patient or get an urgent review from the neurologist if they've got the following symptoms. So motor weakness, i.e. loss of power and weakness in their arms and legs so they can't move. Double vision shouldn't be happening. So remember, we talked about zigzagging and little dots in the vision, but double vision shouldn't be there. Visual symptoms affecting only one eye. So remember, if somebody's got a migraine, it's going to happen in both eyes, not in one side. This one here, so the balance, if the balance is poor, that indicates that something more serious is going on. And of course, decreased levels of consciousness, which may be that the patients, themselves or their partner or their carer has said, look, Mr. So-and-so is quite drowsy compared to how he was yesterday. Those are the kind of things that would make us think, okay, this isn't a migraine with an aura. This is an atypical aura, which indicates some kind of central nervous system issue like a stroke or a TIA. And we need to urgently admit these patients to the medical unit for further assessment. Then you've got an aura without a headache. So this is quite common, migraine attacks where you get aura, where there's no aura, they just get this one-sided headache. Normally, what they say is that the absence of a headache makes exclusion of other causes, such as a TIA, difficult. This is a tricky one, but the investigation is often indicated, especially if you get an aura without migraine headaches, and that occurs for the first time after 40 years of age. So 40 years of age, someone who starts coming into your surgery or your A&E clinic, and they've got their first ever migraine after the age of 40, you have to be very confident that this is not something else, because most people who have a migraine will have most likely had one and would have had a few attacks throughout their life, perhaps in their teenage years, early 20s, and so forth. Good. How do we manage these cases? So key things to remember then. So nice summary here of how you should manage it. So the guys who've been to the PLAB 2 online academy have got a good system now. They're 5 days into their teaching, so they know how they should be structuring their management, because this is the main reason why people fail PLAB 2. And of course, from a PLAB 1 perspective, you need to make sure that when you're asked to manage a clinical case in the PLAB 1 exam, it's in line with the current NICE guidance. And that's the most important thing with current, because the NICE guidance does change. And if you don't stay on top of that, you could end up answering it incorrectly. So key things to remember. When we're managing patients, there's things that they can do, such as keep a headache diary. So work out when they get the headache and what were they doing at the time, what did they eat, what did they drink. So you can try and look for triggers, which leads you on to point number 2. And obviously, if we know what triggers the patient has, then we can avoid them. Stress management. So often stress can trigger off migraine. So you should be able to signpost. So signpost means direct patients towards things they can use to support themselves. So things like, self-help apps, YouTube videos to manage stress. Of course, things like exercise, deep breathing exercises and so forth. And then the final 2 points is making sure that they've got good sleep hygiene. So They make sure that they're getting at least sort of between 6 to 8 hours a night, and ensuring good fluid intake. And by fluid intake, although you can have stuff like tea and things, but obviously making sure there's lots of water in the diet, because things like tea and coffee can actually dehydrate you in large amounts. So the top tip for you guys, okay? So we talked about one of the triggers for migraine is actually overusing the actual migraine treatment medications. So what can we do? Well, the first thing is that medication overuse headache is very common in people with migraine. So NICE says you can avoid it by restricting giving acute medications to a maximum of 2 days a week. So if you start prescribing, a 10-day course, you're going to leave your patients more at risk of developing a medication overuse headache. So in the UK, what we tend to do is, for example, we'll talk about triptans in a minute. We give a drug called sumatriptan. We normally give them 6 tablets. In the pack, 6 tablets come, and that just means that they take that sumatriptan when that headache starts. But they've only really got enough to use, for maybe 2-3 attacks. So what medications can we give adults? Well, in adults, NICE has got some interesting things. So the first step is that we can give them simple analgesia, so ibuprofen, as long as there's no contraindications like asthma, because of course then we have to be careful and avoid. You can give 400 milligrams, but actually if you really want, you can increase the dose to 600 milligrams, or the second option is give them 900 milligrams of aspirin, or the third option is 1 gram of paracetamol. Then there's the next bit. Now, if that doesn't do the trick, we can offer them a triptan medication either on its own or combined with paracetamol or an anti-inflammatory drug like ibuprofen. So the first one that we tend to give in the UK is oral sumatriptan, and normally the first dose is actually 50 milligrams. And what we say to our patients is that if the headache, so as soon as the headache starts, take this medication. If your headache does not terminate, then you can repeat the dose within 2 hours. If there's a vomiting issue going on, then we can give them a nasal version of this drug. So there is a nasal or a subcutaneous, but normally the intranasal version of sumatriptan is a spray that's sprayed into the nose. And if you have got a patient who's complaining of a headache with vomiting, then we can go down that route. And of course, we can give them anti-sickness medications. The common 2 that we prescribe here are metoclopramide at a dose of 10 milligram, or prochlorperazine at a dose of 10 milligram. And of course, metoclopramide, we should be careful that we don't use it regularly, because the patients can get extrapyramidal, so Parkinson-like side effects. So we tend to give metoclopramide for short courses, maybe sort of 3 to 5 days. So top tip number 1 for you guys, if they have an aura, triptan medication should be taken at the start of the headache and not at the start of the aura, unless the aura and the headache occur together. So that's a top tip for you guys. And also follow up your patients within 2 to 8 weeks. So I normally bring them back within 3 to 4 weeks, but 2 to 8 weeks is your safety netting way to say, look, I'm starting you on this treatment. If it's okay with you, would like to see you back in 2 weeks. How does that sound? So you're coming up with a shared management plan with your patient. The top tip number 2 is when you're dealing with this in a station for PLAB 2, or you're asked a question in your PLAB 1 exam about the side effects of a triptan, make sure you counsel your patients about the key side effects. And the most important ones are you can get this heaviness or pressure or tightness anywhere in the body, but often in the chest. And although it could be anything, it might just be anxiety, it could also be because the medication is called coronary artery vasoconstriction or anaphylactic reaction. So that in that situation, the patient has to stop the medication and seek an urgent medical review via 999. There's a subtle difference when we talk about migraine in adolescents. So my teenagers quite commonly come in with migraine. It's a common presentation that they have. The first line is exactly the same. So you can offer them paracetamol or anti-inflammatory like ibuprofen, unless they've got asthma. Number 2, we don't give them the high dose aspirin like we do with adults, because aspirin is contraindicated under the age of 16 because of the risk of Ray's syndrome. And so what we offer them, we don't offer them oral triptan, we go for a nasal triptan. This is an important distinction if you're managing a PLAB 2 case with a teenager with a migraine, or you're managing a PLAB 1 question with a teenager with a migraine, the first option for them wouldn't be an oral triptan, it would be a nasal triptan, such as nasal sumatriptan, because oral triptans are not licensed under the age of 18 in the UK. Number 4, if the nasal triptan is not working, we can add in combination therapy where you give the nasal triptan and an anti-inflammatory, or a nasal triptan and paracetamol. And of course, step 5, you can add in a sickness medication like metoclopramide or prochlorperazine, and you should also make a follow-up within 4 weeks. Then you've got the prevention. So we have propranolol, which is the #1 preventative medication that we give adults in the UK at a dose of anywhere between 80 to 160 milligrams, but it's divided. So normally I would give 40 milligrams in the morning and 40 milligrams in the evening. Be careful, because propranolol is a beta blocker and that's contraindicated in asthmatics. So be careful when you're dealing with a patient who's got asthma. So if you're reading a PLAB 1 question and they're asking you about migraine prevention and they tell you the patient's got asthma, your correct answer would not be propranolol, it'd be topiramate. And the same thing if you're dealing with a PLAB 2 case with a migraine in a asthmatic. The second step, the second preventative drug that we give to patients who have recurrent bouts of migraine is topiramate at a dose normally titrated, so starting off at 50 milligrams, working up to 100 milligrams a day in divided doses. But remember, you cannot give this drug. It's contraindicated in pregnancy because it's highly teratogenic. So if you have a woman of childbearing age, you have to counsel her on this. She has to accept the risks. And if she's not obviously not pregnant, you have to give advice on effective contraception, or indeed even avoiding anything while you're on this medication. Number 3, the third option is amitriptyline. We normally start that off at 25 milligrams a night. You can work up to 75 milligrams, but the common side effect of this is the patients can report drowsiness. Sometimes they can get things like dry eyes and urinary retention as well. So do look out for these. Something which has changed is that we do no longer offer gabapentin for migraine prevention. So it's something which has been mentioned in the NICE guidance, up-to-date guidance. What other things can we do? Well, there's non-drug treatments as well. So NICE mentions that you can focus on behavioral things, so relaxation techniques, mindfulness therapy, cognitive behavioral therapy. Number 2, there's the option of acupuncture, up to 10 sessions over sort of 5 to 8 weeks. And this is not a bad option if both topiramate and propranolol are not suitable or don't work in your patient. Number 3, you've got the option of riboflavin at 400 milligrams once a day, and that can help reduce the frequency and intensity of migraine in some people. But again, we need to avoid this if you have a pregnant patient or a female patient who's planning to become pregnant. Finally, menstruation. So some female patients will come in and they will get period-related migraines. And so actually you've got a slight variation here. So rather than sumatriptan, we can offer them frovartriptan. So they've similar medications, but they seem to work more effectively in menstruation. So frovartriptan is given at 2.5 milligrams twice a day on the day of the migraine is expected, or from 2 days before until 3 days after the period starts. The second option is zolmitriptan at 2.5 milligrams twice or 3 times a day, again on the days the migraine is expected, or from 2 days before until 3 days after the bleeding starts. Pregnant or breastfeeding women and migraine, what should we do here? Just let them know. So we know that possibly is a trigger. So the first step for a pregnant or breastfeeding woman, we have to be very careful in what we give. So normally reassure them that by the 2nd or 3rd trimester, it will go away. So normally paracetamol is fine, but mainly lifestyle measures, cognitive behavioral therapy. So, stress management, relaxation techniques, mindfulness techniques, cognitive behavioral therapy. If that's not effective, we can offer paracetamol. If that's not effective, step 4, you can consider ibuprofen, but only in the 1st and 2nd trimesters. After that, when you go into later in pregnancy, there's a risk of closure of the ductus arteriosus, and obviously that can be detrimental, so we can't give ibuprofen then. Number 5, we've got the option of the triptan, but preferred triptan in pregnancy. And like I said, avoid the NSAIDs in the 3rd trimester because there's a risk of premature closure of the ductus arteriosus. Number 7, do not prescribe aspirin or opiates for migraine in pregnant or breastfeeding women. And if you're going to talk about preventative treatment, it shouldn't really get to this, but if it does, the patient should be discussed with a neurologist you can offer some advice, because again, we have to be very careful and ideally avoid preventative medication in women who are pregnant or breastfeeding. Good. So nicely comes to the end. I think there'll be a couple of things just to look out for just while that's loading up. So make sure you keep a lookout at our social media. We've got lots of learning for you guys. We've got Instagram, inspire_medics, where we post lots of daily revision material. And keep you up to date with all our projects that we're doing in preparation for PLAB 1 and PLAB 2, as well as life in the UK as doctors. Our Facebook page, inspire_medics home. YouTube as well, so we've got some fantastic short revision videos that we're making on the current NICE guidance, which are available on Inspire Medics. You can also watch our examination videos on there if you're preparing for PLAB 2. Twitter is very useful, so I don't know if you guys use Twitter, but if you're on there, have a look for us on Inspire_medics. Very useful if you're planning to come to the UK, because we have, apart from the revision material that we post, we also try and keep you up to date with the latest UK news, things, updates on the exams, and also kind of, allow you to get ready for life in the UK. And we'll be also going into the visas and things, which myself and Dr. Mo will talk a little bit about later on. You may be on LinkedIn, but Inspire Medics Limited, it's worth having a quick look for us on there as well. So I shall stop the screen share and open up for questions.
BKS, that's okay. If you don't mind muting your mic, I'll bring you up to speed. So I've answered most of the questions as you were talking. Actually, there might be one or two still there possibly. So guys, you won't be able to see me now because there's some slight technical issues, but you should be able to hear me. So a couple of quick things. The discount code for the PLAB 2 Online Academy is only valid for today. It ends in 8 hours. It's 50/20/20. So once you choose your date and add to cart, you get to the cart page. At the bottom of the cart page, there'll be a button saying applied coupon. Click on that, and then you can enter your coupon code. So the discount code for the PLAB 2 Online Academy, £50 off, only for today, is 50/20/20. And of course, if you choose a date later on in the year, we can move you to a different date if your exam dates, you're not sure of which PLAB 2 exam date you're going to do. The second thing is the PLAB 1 mock. The discount code for the PLAB 1 mock is 25/20/20. And it's £25 off. Again, guys, it finishes at the end of today. So use it today. Otherwise, you will not get those discount codes. And it's only for you guys. Only the people who attend these webinars get these codes. Nobody else gets them. So again, use them as soon as you can. The only other thing is we have a video course. It includes SimMan, and I've included the link within the chat. I think that's it pretty much from me. I know you guys can't see me, but Vikas, do you want to add anything? If you put your mic on.
Okay, I think there's a question that's come up, actually, an interesting one. So Hina's asked a question about, can you please explain ocular migraine? So that's a good question. It's a very rare condition and something which it's unlikely that you get asked, but ocular migraine it's got another name. It's called retinal migraine. It's an eye condition where you get a very brief blindness, basically, or very brief kind of flashing of lights, normally in one eye. And patients do find it quite distressing, actually, because it's just come out of the blue. But it's not like the migraine with aura. Remember, it's a different thing. So migraine with an aura is going to be a zigzag. You're not going to lose vision in the same way a retinal migraine would. So it's a separate condition, actually. And like I said, it's a partial or total loss of vision in that one eye. The diagnosis is interesting because actually it's hard to diagnose. You normally diagnose it on a history, because by the time a GP or an optician has a look in the patient's eye, you're unlikely to see. There's normally going to be reduced blood flow, but you wouldn't see it because the attack's normally gone by then. So in those kind of situations, really, it's offering obviously pain relief if they're having any symptoms like headaches, but mainly it's eye clinics, so you can get them referred to the eye clinic and they'll get assessed. But it's a very niche question, a good question, but not something that you specifically need. Next question. Thanks for the insightful lecture. Thank you very much. I'd like to clarify if the medications can be prescribed in a GP clinic or patients has to be referred to hospital. So basically, migraine is something you should be able to manage in primary care. So in the UK, GP is called primary care. So basically, you should be, all of those things can be initiated by GPs. You'd only get the neurologist involved in more complex cases like women who are pregnant or planning on getting pregnant, or if there's contraindications, for example, it's an asthmatic, in which case you can't give the beta blocker, but she's also planning a pregnancy, so you can't give topiramate. So lots of different factors to take in, but all of these medications can be given in kind of, you know, primary care.
Okay, guys, very quick shout out then. The discount code can be applied on top of the discount already on the website. There's a countdown on the website. You can apply the discount code on top of that. Just once more, the online PLAB 2 Academy, the discount code is 502020. You get an extra £50 off. And the PLAB 1 mock is 252020. You get an extra £25 off. There is another teaching webinar in the next 1 to 2 weeks. We will email you the link. Make sure you join us. And we're going to have to wrap this one up, guys, I think, soon, because there's a jobs webinar we're going to do very, very soon. There is a question from Anila, and we can, guys, if there's any other questions, if you don't mind, if you email them to us at info@i-medics.co.uk, and we can basically answer them via email as well. Vikas, the very last quick shout out, and then we'll do a wrap this up.
Yeah, thank you very much, guys. So if you have any feedback, do let us know. Anila, I think you've got a medical question. Do drop us an email, and we're happy to answer that for you, or even WhatsApp us if you've got us on there. So, as I said, if you're getting ready for the exams, do let us know. Do let us know how you found the session. We'll just leave it running for about 30 seconds, just so if you've got any feedback on Zoom, you can feel free to type it in, or if you found it useful, do recommend it. So PLAB 1 question bank, so make sure you use that question bank. It's free, it's made for you guys. We're updating it with the latest questions. I also think that the PLAB 1 mock is coming up in October. It's about 2 or 3 weeks away, it's not far now. So if you're preparing for the next PLAB, do join us for that, because that's quite an intense day. You get to do the mock in exam conditions, you know, for kind of 2 or 3 hours. It's in the morning, and then in the evening, me and Dr. Mo come back on like we have here, and it's just full on teaching. And it's really good because we've done it we do similar mock exams for GP trainees in the UK, and they find it really useful because actually you cover 180 plus different topics, and we prepare slides. So we've got, you know, you can talk about migraine, and you can talk about eye problems and skin problems and A&E problems and all that kind of stuff. So do use that. Thank you, Shazia, for your feedback. Question bank for PLAB 1 is awesome, which, you know, so we always appreciate that when you guys, you know, find it all useful. And also just kind of make sure that, but yeah, so yeah, so use that. So that stuff's there for you guys. Use the social media, because again, I think that will be useful. Like I said, if you're prepping for PLAB 2, so Charles is coming in. We like Charles. He's a part of our first batch of our online PLAB 2 Academy. So Charles has said, guys, register online. You won't regret it, I assure you. You know, so the stuff that we're doing is we're trying to take you guys to the next level now, because the exams are changing. PLAB 1 is changing. PLAB 2 is changing. And both myself and Dr. Mo are now heavily involved, you know, in teaching students both in the UK as they prepare for UK exams, and you guys as you prepare for your PLAB exams. And the only final update is that we will have an update in the coming weeks. So obviously we've got more webinars coming up, so stay tuned, share it with your friends, let them know. We'll be going into the visas as well. So we'll be looking at ways in which we can support you guys to get to the UK, because we know that that's been an issue. So we're talking with lawyers at the moment about whether we can try and get some kind of support in place, where, you know, we can use a legal team, because I know that it's very difficult without that, really, for people to get to the UK. So bear with us. There will be some updates coming up in the coming weeks, but otherwise, fantastic. Thank you very much. We appreciate all your kind feedback, and we'll see you on the next webinar.
All right. Thank you, guys. See you soon.